Hello again, everybody. Thank you again for the opportunity to speak. So I'm now going to be discussing a pilot study that we completed at our institution, focusing on evaluating the prevalence of geriatric syndromes, or as we call age-related risk factors in our elective hernia population. This work is a part of a longitudinal project that our group has entitled the Geriatric Assessment and Medical Preoperative Screening Program, or GrAMPS for short, an acronym that I'm very fond of. We have no disclosures to report for this talk. So as I mentioned in my previous presentation, the United States population is rapidly aging, and due to these demographic changes and concurrent surgical advances, there will be an increasing number of older adults undergoing surgery. While there are clear benefits of surgery in older adults, there is also potential for increased risk of adverse complications. Older individuals present not only with pathology requiring operative intervention, but also with a number of geriatric syndromes, including those you see listed here. These syndromes are associated with aging, and many have been shown to predict morbidity and mortality following eventual hernia repair. The aging demographic, combined with older adult susceptibility to developed abdominal wall hernias, is producing a growing demand for inguinal and ventral hernia repairs in older adults. Concurrently, there is a paucity of literature that objectively defines these geriatric syndromes in elective surgery populations, and it is unknown whether age can predict outcomes in this same patient cohort. It is also unclear which preoperative risk calculators most accurately predict estimated postoperative risks in the older elective hernia population. Given the growing importance of elective hernia surgery in the aging population and the lack of literature surrounding shared decision-making in this vulnerable patient group, our team has initiated a multi-phase project aimed at addressing these important issues. As the initial step in this longitudinal study, we intended to first identify the prevalence of these geriatric syndromes or age-related risk factors in our hernia population. Patients were enrolled prospectively if they were 60 years of age or older and had a ventral or an inguinal hernia. Exclusion criteria included the following. The patient was deemed to not be a surgical candidate, either they were too debilitated or too comorbid. The patient had a documented history of cognitive impairment, or the plan was to observe the hernia as opposed to operate either due to the surgeon's recommendations or patient preferences. After informed consent, subjects completed numerous validated screening tools at their initial surgical consultation, targeting the assessment of various geriatric syndromes. You can see the various screening tests listed here, focusing on cognitive impairment, frailty, functional dependence, and depression. During our study period, 70 of 74 consecutive patients were enrolled for a 95% enrollment, and all 70 patients completed every preoperative screening test. You can see that 35% of patients were clinically obese, and there was a near equal split between ventral and inguinal hernia patients. The study population had high levels of both objective and subjective unrecognized cognitive deficits, with nearly 35% screening positive on a mini-cog test. You can see here some examples of the clocks that patients drew during their mini-cog screening. They were asked to draw a clock face reading 11:10. And just as a reminder, these were patients who had no known diagnosis of cognitive impairment and were offered an elective hernia repair. Furthermore, over 1/3 of enrolled patients self-reported their health as fair or poor. 85% met criteria for polypharmacy, defined as greater than or equal to 5 daily medications, and 95% of patients met criteria for multimorbidity, defined as a Charleston comorbidity index greater than or equal to 3. And interestingly, when the enrolled patients were preoperatively characterized into tertiles based on their chronological age, we found that traditional risk screening tests that rely heavily on chronological age for risk assessment, such as the Charleston Comorbidity Index or NSQIP, predicted either significant or strong trends toward increased risk estimation in the older patient cohorts. Conversely, when comparing average risk scores generated using the MFI-11 calculator, which is a newer risk assessment based on comorbidities and not chronological age, no statistical trends between the age-based cohorts emerged. When we look at the prevalence of positive screening tests in these same cohorts based on age, we found no difference between the cohorts. This included no difference in the positive screens for subjective health rating, cognitive impairment, frailty, functional dependence, or polypharmacy. So how did these patients fare postoperatively? After evaluating these cohorts for postoperative outcomes, there were no differences between the age cohorts. There were no differences in length of stay, ICU stay, postoperative complications, wound events, readmissions, emergency room visits, or non-home discharge. In conclusion, there were several key findings from this pilot study. First, the incidence of unrecognized cognitive impairment in this population is startling. Second, the rates of multimorbidity and polypharmacy were higher than previously reported in other patient populations. And lastly, our results suggest that age alone inconsistently predicts the prevalence of key geriatric syndromes and may not be an effective screening measure to predict key surgical risk factors. Furthermore, surgical risk calculators that rely heavily on age may not capture an older hernia patient's true risk. Thank you very much, and I'd be looking forward to your questions.